Dr. Remy.
Good morning all. I'm Dr. Hema. I'm presenting a study on origin of fluid in optic with maculopathy, a study in surgically managed patient with scleral plug. So optic with maculopathy was first described by Ved and its incidence is 1 in 10,000. And it should be noted that maculopathy can occur from 25 to 75% of patient, which is a notable number. The origin of fluid in optic with maculopathy is controversial. It is either thought to be from the vitreous due to the negative pressure induced by the VMT, in which liquid vitreous can enter the subretinal space, or from the cerebrospinal fluid, which is due to the direct communication between subarachnoid space and subretinal space. So the aim of our study is to find out the origin of fluid in optic pit maculopathy. The treatment modalities now available is also again controversial. Vitrectomy, plugging of the pit with different materials like platelet, fibrin glue are tried, and juxtapapillary laser, ILM peeling, etc. are tried. Our study is a retrospective study of 13 patients who underwent total pars plana vitrectomy with autologous scleral flap and C3F8 gas from a period of September 2013 to September 2022, and the cases which could not be followed up within 1 year was excluded. A detailed history was taken, slit lamp examination, fundus examination was done, pre-op and post-operative best corrected visual acuity was done, and these data were retrieved from electronic medical records, and 2 senior surgeons has performed the surgery. Coming to the surgery, a brief. We did a 23 gauge vitrectomy. Now we are doing a 25 gauge vitrectomy. A PVD induction was done. A partial thickness scleral autograph was taken from the supratemporal quadrant away from the limbus, and it was plugged into the optic pit. We didn't do an ILM peeling in any case, but PVD induction was done in all cases. C3F8 laminate was done, and prone position was given for 1 week. The OCT analysis was done in raster scan in Spectralis Heidelberg engineering machine of both disc and macula, and pre-op post-op evaluation was done, and statistical analysis was done in SPSS software. There were 5 males and 8 females. All had unilateral disease. Mean age was 35 years. One patient had a retinochoroidal coloboma and intraocular pressure was normal. The median BCVA pre-op was 636, which improved to 618. And notably, 39% patient had a 4-line gain and 30% had a 3-line gain. The preoperative disc changes, which is a very striking feature we could see, was that a communicating tract, which is already described in literature, was seen between the subretinal space and the perineural space, and other features like hyperreflective spaces were seen beneath the membrane seen on the disc. These are the subretinal, the tract which is connecting the perineural space and subretinal space explained, and we could see the tract is present in almost 80% of our cases. Post-operatively, this is one case. After 6 months of the scleral graft, we could see that the tract is obliterated and the fluid has resolved. This is another patient for whom the scleral graft was dislodged at 1 day post-op, but surprisingly for that patient also, at 1 month itself, this fluid has started resolving. So a mechanical pressure, is it only sufficient than an anatomical closure, is questionable. Coming to the OCT macula, preoperatively, retinal schisis, inner and outer was seen in equal proportion in all cases. Inner retinal fluid first appeared, and outer retinal fluid first disappeared. Also, in cases even for whom that surgery was not done, when we checked retrospectively, inner fluid was the first to appear. Central macular thickness, about 40% cases, 50% reduction was there, and 30%, 70% reduction was there, and it was well correlating with the BCVA gain and decrease of fluid. OCT postoperatively, only 10% patient had normal OCT at 1 year, and 70% had outer retinal schisis. So this is the current concept of fluid origin in optic pit maculopathy. The vitreomacular traction has causes a negative pressure which can cause a fluid from the perineal space. Do we agree with this? Yes. We could see a tract, and there was fluid which appeared to the tract in the inner retina first. But what we couldn't see was that there was no PVD in any of the cases, and there was no VMT. So we don't agree with the vitreous traction theory. So our humble attempt to explain the origin of fluid in optic pit maculopathy is that a congenital optic pit tract is there between the subarachnoid space and the inner retina. And what causes the fluid to percolate into the inner retina can be anything, either a physiological process like well-defined CSF fluctuation, which can be diurnal or postural, which causes the fluid. And when a
time is
ma'am, the CSF theory is already well explained, ma'am. But the origin of why this fluid is coming to the subretinal space is postulated only, that they are telling it can be without any cause, or can be from the VMT, which causes a negative traction. So we think that since our cases didn't have a VMT, we think that can be any physiological process. For example, can be a CSF fluctuation also. But we are not sure about this is just our postulate. Um, this CSF study and all is done, ma'am, which shows that the potassium and the cellular constitution of this fluid is similar to CSF study, but we couldn't we have not done, ma'am.